Vice-Chancellor and Principal of the University of Pretoria, Professor Tawana Kupe, Professor Norman Duncan, Vice Principal Academic, members of the University of Pretoria Executive, Professor Albert van Schoor, Professor at the Department of Anatomy, Faculty of Health Sciences, members of the Faculty Executive, including our school chairs, distinguished guests, colleagues, and students. I'm Tiande Jager, Dean at the Faculty of Health Sciences at the University of Pretoria. This evening's inaugural address will be presented by Professor Albert van Schoor, and he will focus on the anatomy of an anatomist. Please allow me to welcome Professor Norman Duncan to introduce Professor Albert van Schoor. Professor Norman Duncan holds a professorship in psychology and is the Vice Principal Academic at the University of Pretoria. He previously served as the head of the School of Human and Community Development at the University of Witwatersrand and the Dean of the Faculty of Humanities at the University of Pretoria. His research and publications are primarily in the fields of human development, racism, and community psychology. His current research interests are focused on teaching and learning in higher education. He is a former president of the Psychological Society of South Africa and currently serves on the council of the Academy of Science of South Africa. Professor Norman Duncan.
Members of the University Executive, members of the University Council and Senate, Professor Tiande Jager, Dean of the Faculty of Health Sciences, his Deputy Deans, Professor Vanessa Steenkamp and Professor Tivani Mashamba Thompson, other academics from the University of Pretoria, as well as colleagues from other institutions of higher learning, and of course, Professor Albert van Schoor and Professor van Schoor's family and friends. Colleagues, ladies and gentlemen, it is my signal pleasure to welcome you on behalf of the Vice-Chancellor and Principal of the University of Pretoria to the inaugural address of Professor Albert van Schoor. Colleagues, ladies and gentlemen, you will acknowledge that we are living through a period of dramatic change. Apart from unprecedented technological innovations and change over the last 2 decades at least, the world has also had to contend with the extreme disruptions as a result of the COVID-19 pandemic these past 18 months. All of these changes have required radical adjustments on the part of most sectors of our society, including the university sector. While the University of Pretoria prides itself in its flexibility and its ability to manage change when change is required, it also strives to foster continuity of that which it holds dear, such as academic excellence and the rigor and depth of the scholarship embodied by its senior academics. Of course, the university counts amongst its own a large number of senior academics who epitomize academic rigor and excellence. Colleagues, ladies and gentlemen, based on my reading of Professor Albert van Schoor's academic resume, he undoubtedly can be viewed as representing the best qualities of this grouping of scholars. And given that he is a full professor, he has been invited to present his inaugural lecture today. As you may know, the University of Pretoria last year confirmed that being a full professor should be the only criterion for presenting an inaugural lecture. Colleagues, ladies and gentlemen, an inaugural lecture represents one of the most important milestones in the careers of academics and provides newly promoted or newly appointed professors the opportunity to inform the university community and academia more broadly about their academic journeys and more specifically about their research to date, as well as the direction in which they hope to steer their research endeavors in future. Above all, for us at the University of Pretoria, an inaugural lecture provides the university an opportunity to celebrate the academic achievements of the newly appointed or the newly promoted professor. At this point, colleagues, ladies and gentlemen, allow me to introduce Professor Albert van Schoor to you. Professor Albert Niels van Schoor is the youngest son of Niels and Theonice van Schoor. He has been married to Robin Ann Meyer for close on to 17 years. Robin and Albert have 2 young children, a son named Neil John, who was born in 2018, and a daughter, Hayley Ann, who was born in 2020. In 1999, Professor van Schoor registered for a BSc Medical Science degree at the University of Pretoria. 4 years later, after graduating and completing his honors degree in neuroanatomy, cum laude, he enrolled for an MSc, also in anatomy, which he completed also cum laude in 2004. By this time, he had accepted an academic position in the Department of Anatomy at the University of Pretoria. He obtained a PhD in 2010, also at the University of Pretoria. Ladies and gentlemen, the clinical anatomy of regional nerve blocks, especially in pediatric populations, as well as studying the position of these nerves, have long constituted a key focus of Professor van Schoor's research. Additionally, in recent years, with the rapidly growing availability of increasingly advanced imaging technologies, he has been steering his research towards including a focus on imaging modalities and the use of ultrasound-guided clinical procedures. To date, Professor van Schoor has published more than 40 articles in peer-reviewed scientific journals, and he has had the opportunity to present on his research at a range of international conferences and at the meetings of the American and British Associations of Clinical Anatomists. According to Professor van Schoor, much of his research success can be linked to his successful recruitment, mentoring, and supervision of postgraduate students. To date, he has supervised 13 MSc and 5 doctoral students to the successful completion of their studies. In 2008, Professor van Schoor was elected to the Council of the Anatomical Society of Southern Africa. He thereafter was appointed the Honorary Secretary of the Society for 2 successive terms, and more recently, he was elected President of the Society. Furthermore, Professor van Schoor currently serves on the editorial boards of a number of journals, including Neuroscience Imaging, Clinical Anatomy, and Translational Research in Anatomy. He's also an active reviewer for the journals Clinical Anatomy and Surgical and Radiological Anatomy, as well as the Journal of Clinical Anesthesia and the Journal of Anatomy and Pediatric Anesthesia. During the past decade, Professor van Schoor was invited to serve as a co-author for both the 7th and 8th editions of the Abrams and McMahon Clinical Atlas of Human Anatomy, and the atlas was published, or the volumes were published in 2013 and 2019 respectively. Professor van Schoor's other contributions to science include co-authoring a chapter on the variations of the arteries of the spinal cord for the Bergman's Comprehensive Encyclopedia of Human Anatomic Variation. This volume was published in 2016. More recently, Professor van Schoor contributed a chapter on the anatomy of the respiratory diaphragm and phrenic nerves for the 42nd edition of Gray's Anatomy. In addition to all these scientific activities and accomplishments, over the past 15 years, Professor van Schoor has been actively involved in teaching undergraduate and postgraduate students, and he currently serves as a founding member of the global community of anatomical science educators. Colleagues, ladies and gentlemen, I now invite Professor van Schoor to present his inaugural lecture titled Anatomy of an Anatomist, Imaging Modalities in Translational Anatomy, Teaching and Research. Over to you, Professor van Schoor.
Good evening, and thank you, Professor Duncan and Professor De Jager, for the kind introduction. It is a singular honor to be able to present my inaugural address to you, members of the faculty, colleagues, friends, and family. Even though this might not be the platform that we all expected, a major benefit of a virtual inaugural address is the fact that family, friends, colleagues, and some of my most distinguished mentors and friends can be present to watch. Needless to say, there are many I would like to thank personally for the support that they have provided. Over the span of my career, Obviously, I would like to thank everyone who is watching this from their homes, but I would especially like to thank the love of my life and beautiful wife, Robin. Without her support and motivation, this would never have been possible. Although they are too young to know it, I definitely want to mention our two wonderful kids, Haley and Neil, both of whom are probably having supper right now, and I love you guys very much. Of course, I would also like to acknowledge my father, Niels, and mother, Tunise, for all of their support, guidance that they've given me over the last couple of years. I cannot thank you both enough. You are an inspiration, and I love you very much. Of course, I would also like to thank my mother-in-law, Anne, for her constant support and love. I also have to acknowledge my brother, Yaku, and his lovely wife and the best sister-in-law, Laura, as well as Peter Richards and his wife, Leanne, as well as their two beautiful kids and our godchildren, Liam and Alexa. It would be an understatement to say that all of them did not have a profound influence on me over the years, and I cherish all of the time that we spend together. Now, it is difficult with this limited time that I have to thank everyone individually, but I have at least to give a shout out to the rest of my family, as they also have had a significant impact on my life. My uncles and aunts, cousins and their spouses, if you are watching this, thank you. I know for a fact that my Oma Louise and Opa Albert would have been very proud of me today. And lastly, I would like to thank and acknowledge the staff of the Department of Anatomy, the ones that are still there right now and battling through all the same difficulties on a daily basis. Without them, this definitely would not have been possible. But also to those who have left and gone on to bigger and better things. In the 18 years that I've been in the department, there have been many who have come and gone and yet have had a profound impact on me. But you are actually here to listen to my address, and the title of which is Anatomy of an Anatomist, Imaging Modalities in Translational Anatomy, Teaching and Research. The topic was really a way for me to reflect upon my journey as an anatomist, but it also allows me to discuss some of the imaging modalities that I have had the privilege of using in anatomy research. As you will see, there are imaging modalities that can be employed in most anatomy research projects to increase the translatability of the work into the clinical spectrum. I'm also by no means the only staff member in the Department of Anatomy employing imaging modalities in their research. Unfortunately, I will not have the time to cover the wonderful work that they are all doing as well. Now, as a slight tangent to the topic, however, I would like to talk a little bit about my being an anatomist and some of the challenges that we face on a constant daily basis. I will not be including the work that Bekengse Africa project is doing, the goal of which is especially to develop and manage comprehensive digital imaging collection in Southern Africa. And if you want to know more about this, you can go visit their website. Now, clinical anatomy is arguably one of the most valuable subjects to any medical practitioner and is often defined as anatomy applied to patient care. My old mentor and supervisor, Professor Hanu Boon, would often emphasize how, especially in developing countries such as South Africa, doctors are often dependent on their anatomical knowledge for the successful performance of clinical procedures. This notion has also been echoed by many of the great anatomists that I've come to work with. Even the American Association of Clinical Anatomists agree that clinical procedures that fail to achieve the required results or that result in complications can often be linked to a lack of understanding or a misunderstanding of the anatomy relevant for that specific procedure. And even as far back as 1973, a very well-known anesthesiologist, Alan Palm Winnie, stated that no technique could truly be called simple, safe, and consistent until the anatomy has closely been examined. Now, despite the emphasis that many practicing clinicians place on a good anatomical foundation, human anatomy is a discipline that has gone through many transitions brought on by the exponential expansion of medical knowledge, increasing student numbers, decreasing dissection time, moving an integrated clinically based curriculum, and increased access to advanced imaging modalities in a clinical setting. With the new 2025 revision of the medical curriculum, anatomy dissection will now be part of a system-based integrated module, which means that anatomy being taught needs to be translational. Additionally, limited dissection time, be it from or a decrease in the dissection hours available, or because of the COVID-19 restrictions, as in the case of the last 2 years, we as anatomists need to find innovative methods for students to study and understand the anatomy that is relevant to them as future doctors. They need to learn the soft skills that can only be gained by being exposed to the safety of full-body human dissection, where they can explore the human body in a controlled and supervised environment. But they must also be challenged with the living anatomy visible on different imaging modalities. Students should be able to appreciate the inter-individual variations that are present with all their patients and not just see anatomy as the static, drawn illustration that they see in the Netta Anatomy Atlas, when the actual fact the anatomy often appears much different. This is also predominantly why the anatomy staff, including myself, strive to produce anatomy research that can translate into the clinical spectrum. We employ imaging modalities in the research studies we design, not solely to include an aspect of the living anatomy to our studies or to make it more clinically relevant, but also to produce research that can be incorporated into the anatomy that we teach. Therefore, this address aims to present imaging modalities, both conventional and modern, for anatomical research, and hopefully also reflect on the critical role that clinical anatomical research plays in the clinical arena, how this research is driven by collaborative anatomy teaching, and how the teaching is guided by the research. The focus will be on studies that employ real-time ultrasound imaging, computed tomography or CT imaging, and micro-CT to create three-dimensional person-specific anatomical models and highlighting the value of paired cadaveric and imaging studies. I would like to present some research projects that highlight the key aims of this address, although there are many other contributions that could have been included. In consideration of time, however, I just could not include all of them. Just a very quick disclaimer, this is an anatomical presentation, and as such, I will be showing some images that might disturb some of you, especially if children are watching this address. So viewer discretion is please advised. I feel it important to mention that when I refer to a cadaver, I'm specifically referring to an embalmed body. Now, these individuals are predominantly donated to the Department of Anatomy under the rules and regulations in the South African National Health Act 61 of 2003, and all activities within our institution is monitored by the Inspector of Anatomy of Gauteng. Images will be edited to prevent the identification of any of the donors, and all images that are taken are used for teaching and research purposes and not posted on any platform that is accessible by the public. Now, before I continue, here's the first part of the tangent that I mentioned. Now, I would like to digress slightly and talk about some aspects of my career thus far. Now, my first day of work was at the department was 1 April 2003 as a technical assistant. I acted as a liaison between the technical and lecturing staff, and my role was to make sure that the practicals were ready by the time the lecturer arrived at the dissection hall. Now, once I even was asked to present sort of what the role of a technical assistant within a department is, and the main takeaway from that lecture, as well as my time as a technical assistant, is that all of our work needs to be done behind the scenes. Although not a thankless job, it is one where the job satisfaction came without overt praise and fanfare. Now, although it doesn't look like it, I loved my time as a technical assistant. I was perfectly suited for the job, and it was something that that really provided me with the correct perspective of the role of an anatomist within any faculty of health sciences. There are other benefits to my early career in the department. Firstly, I was afforded the opportunity to pursue my postgraduate studies while being in the employ of the University of Pretoria. Secondly, with a stable job, I was able to marry my beautiful wife, Robin, and while she was still studying medicine. And lastly, I was in an environment rich with knowledgeable mentors. Now, these included, to mention but a few, Professor Hanu Boon, who was a singular and lasting inspiration in my development as an anatomist prior to his untimely death in 2004. While still doing my master's, Professor Boone sent me to Cambridge University on a travel bursary, and there I met his PhD supervisor, Professor Peter Abrams. Now, Peter always has been a mentor and someone I looked up to, but since our meeting in Cambridge, we have become colleagues and, most importantly, friends. He has been at the forefront of many of my subsequent achievements within the profession, and I will never forget our long work days at St. George's University working on the 8th edition of the Abrams and McMillan's Atlas. Now, another important person in my career that Hanu also introduced me to was a pediatric anesthesiologist out of the Red Cross Children's Hospital, Professor Adrian Bosenberg, who has been a source of inspiration and guidance since the very beginning when I was still tentatively finding my research niche. Even before he was my PhD co-supervisor, he invited me to anesthesiology workshops and co-authored many subsequent publications in the field. Even now, he is still co-supervising the PhDs and co-authoring publications with myself, Dr. Lene Prigger, and Dr. Sebastian Govender. And finally, I have to mention Professor Marius Bosman, who not only took over the reins of the section of clinical anatomy after Hanu's unexpected passing, but he also accepted the responsibility of taking over the role of my PhD supervision. In time, we became fast friends and also a very good team. I'm sure that our work together and our research together shows this. We also have had some opportunities to go on some amazing adventures together, be it to the Caribbean or Las Vegas, trips which I will never forget. So I've been blessed with mentors that helped and guided me from early in my career. It was also them who nurtured the manner in which I interacted with my postgraduate students, how we planned and conducted research, and finally how I conducted myself within my chosen field. There were so many others that could also be added here that also guided and supported me throughout my career. Too many to mention in the time allowed, unfortunately, but I would like to give a shout out to Professor Natalie Keogh and Professor Pieter Toy, however. It is now that I would like to highlight some of these research projects that I've been involved in. Now, ones that especially employed imaging modalities as either the sole form of data collection or the ones that where the imaging modalities was used as an adjunct to improve the work. Globally, the scope of ultrasound imaging guidance for regional anesthesia has drastically increased over the past 2 decades. In many countries, ultrasound guidance is a prerequisite for regional anesthesia. What is standard practice in many countries was not so quickly adopted in South Africa, however, despite the proven increase in safety and block success, which led to the development of a study by Dr. Sebastian Govender together with the help of Dr. Shabalala and Dr. Moore, to provide detailed descriptions of ultrasound anatomy of regional nerve block techniques, as well as develop a step-by-step guide to perform ultrasound-guided brachial plexus blocks. Now, ultrasound is used to visualize the anatomical structures in real time during the performance of many clinical procedures. This real-time visualization makes positioning of the needle tip close to the targeted nerve easier, quicker, and safer. However, a sound knowledge of the macroanatomy, as well as the visible anatomical structures displayed on the screen, is crucial in order to perform a successful ultrasound-guided nerve block. Now, despite its obvious benefits, a sound knowledge of the visible anatomical structures displayed on the screen is crucial. Anesthesiologists therefore need a paradigm shift from the normal methods of teaching. They not only need to have a clear 3-dimensional image of the anatomy, but also be able to make mental cross-sections through that image. The only way that this is possible is to have a thorough knowledge of the positions of key structures or landmarks, as well as the relationship of the structures to the above mentioned. So the ultrasound probe in this image, or the transducer, is placed on the skin perpendicular to the musculoskeletal and neurovascular structures you wish to visualize deep to the skin. On this image, you can see the transducer is at the level of the interscalene groove, and you can see the roots and trunks of the brachial plexus as they pass between the anterior and middle scalene muscles. You can take my word for it. That's exactly what you are seeing on that image. Now, with the correct anatomical knowledge, the practical skills you will be able to identify the key structures on the patient. This will also allow you real-time tracking of the needle, which you can see on this image, as it travels towards the intended target. In this case, the branches of the brachial plexus located in relation to the axillary artery, which can be visualized and avoided. And here you can see the needle actually injecting the anesthetic within the axillary sheath and surrounding the branches of the brachial plexus. Now, within the international anesthetic community, there were also murmurs of a new block that simulated a more common paravertebral block. The erector spinae, or ESP block, was considered a novel ultrasound-guided interfascial technique serendipitously discovered while treating thoracic neuropathic pain in adult patients. This interfascial block is hypothesized to target ventral and dorsal rami of spinal nerves, as the block is performed in a tissue plane deep to the erector spinae muscle of the back. With Dr. Govender's growing expertise in conducting research in this field, we were able to develop one of the only ESP studies in children, together with the guidance of Professor Bosenberg and the support of Dr. Moore. Unembalmed neonatal specimens donated to the department through the National Tissue Bank was used in this study. This allowed us to examine the ultrasound anatomy of this fascial space. Now, Dr. Moore was able to simulate the procedure by inserting the needle under ultrasound guidance to the space and injecting a methylene blue solution. Here you can see the needle on its way to the erector spinae fascial plane, and how this plane is filled with the methylene blue, separating the actual structures. Once a predetermined amount of time has passed, Dr. Govender was able to dissect away the layers and reveal the spinal nerves as they exit the spinal cord and vertebral column. She could even note which of the spinal nerves were colored by the methylene blue solution. Another aspect of Dr. Govender's PhD study, after describing the anatomy of the erector spinae fascial plane, was to determine the spread of the anesthetic once injected into the plane using computed tomography imaging. Now, if you don't know, the term computed tomography, or CT, refers to a computerized X-ray imaging procedure in which a narrow beam of X-rays is aimed at a patient and quickly rotated around the body, producing signals that are processed by the machine's computer to generate cross-sectional images or slices of the body. The computer then uses sophisticated mathematical techniques to construct a two-dimensional image slice of the patient at various levels. Again, through a simulated ultrasound-guided block procedure, a mixture of anesthetic solution and contrast medium was injected into the fascial space at two different levels, in line with protocols suggested for thoracic and abdominal regional anesthesia, respectively. Again, after a predetermined time, the neonate was scanned in a CT machine with the kind help from the staff at the Department of Radiology, Steve Biko Academic Hospital. On the lateral CT image reconstruction you can see on the screen, you can clearly see the craniocaudal spread of the anesthetic from the point of injection, allowing for better understanding of the levels of anesthesia that is possible with this block. Now, to highlight how imaging can pair with traditional anatomical dissections, I would like to present the work that was done together with Dr. Marlies Naudé on the comparing visual modalities to evaluate vascular anatomy. In this study, she took 3 different measurements at 20 different arterial sites on 300 individuals, more than 300 individuals. That is over 19,000 individual measurements that was taken. And if that wasn't enough, she then repeated many of these measurements on retrospective CT scans of individuals paired through age, and these measurements were then compared with one another, as well as with measurements of arterial diameters taken from young, healthy volunteers. The latter was done using ultrasound imaging. So Dr. Naudé was able to statistically confirm that the measurements conducted on cadaveric samples compared favorably with similar measurements conducted on living samples using CT scans and ultrasound images. But she also took an important step in the creation of an extensive reference data set for arterial dimensions of a South African population. The final study that I would like to highlight is part of Mr. Edwin de Jager's MSc project, together with Amélie Boudet, now from Cambridge University. The study started at the University of Toulouse, where alternative methods for studying the neuroanatomy of extinct hominids were being investigated. With international collaboration, Mr. de Jager used microfocus CT to scan skulls of extant humans and even chimpanzees. Therefore, he employed a novel method for automatic recognition for cortical sulci in the cranial endocasts. Now, microfocus CT works with the help of a microfocus X-ray source that illuminates a sample. By rotating the sample, several views can be acquired from different angles, and these multiple angular images are reconstructed to create a high-resolution three-dimensional image of the structure. Now, this research was done in conjunction with engineers at the South African Nuclear Energy Corporation, or NECSA. Now, fortunately, the recent introduction of high-resolution imaging techniques in paleoneurology offers new opportunities for tracking detailed endocranial neural characteristics. In such context, the study aimed at providing an atlas documenting the variation in the extant human and the common chimpanzee endocranial sulcal pattern for subsequent use as a comparative platform for the study of the fossil record. Skulls, and in this example, the skull of a chimpanzee, was scanned using micro-CT. Now, micro-CT was chosen precisely because of its ability to obtain information at a high resolution. Often such software such as the Nikon CT Pro was then used to reconstruct the raw two-dimensional projection images into a 3D volume file. Now that you have this 3D reconstructed skull, you can use Endex to virtually create and extract the endocasts. Here you can see that a digital seed was placed into the virtual space of the cranium. Now, this seed will grow and fill the limits of the cranium, which was predefined in the program, and create a virtual endocast, including any impressions that existed on the inside of the crania and cranial fossa. Now, algorithms can then be used to automatically detect sulci and gyri, as well as remove any unwanted distortions detected by the algorithm using MATLAB. This automatic method provides an innovative, non-invasive, observer-independent method to investigate human endocranial structures or structural organizations, and hopefully a promising perspective for discussing long-standing questions in paleoneurology. So with this method, you can clearly define the sulci, gyri, and cortical structures that were significantly large enough to create an impression on the inner surface of the crania, which is significantly more accurate than creating a physical cast of this endocranial structure. Now, before this was possible, however, Edwin had to hone his skills on creating three-dimensional fly-through of an embalmed cadaveric brain. His aim was to create a cast of the ventricles, which we then can use in our teaching of the students. So this will allow the viewer to enter the ventricular system and fly through every component thereof. On the way, the lecturer or demonstrator can highlight key structures of the brainstem or cerebrum that forms the walls of the ventricular system. It also allows the student to appreciate the three-dimensional shape of the ventricular space and surrounding structures, an aspect that is often lost when sectioning or dissecting the brain. Now here you can see the floor of the fourth ventricle with its median sulcus, the two medial eminences, as well as the vestibular area laterally. Now, as we are flying up into the cerebral aqueduct of the midbrain, the superior medullary velum forming the roof, we are going to enter the third ventricle, I will tell you when we get there. So now we are passing through the cerebral aqueduct into the third ventricle. There at the roof you can see the posterior commissure, and eventually you can see the two thalami with the interthalamic adhesion between the two. Now turning posteriorly within the third ventricle, you will be able to see the posterior wall of this space together with the cerebral aqueduct we just flew through, the posterior commissure just above that, together with the pineal fossa and the binular commissure. We can then move forward again or anteriorly again to see the floor and the anterior wall of the third ventricle. The anterior wall formed by the lamina terminalis and the anterior commissure, but if you then turn superiorly towards the interventricular foramina, you can see the two columns of the fornix. We will then pass through the interventricular foramen and directly enter the anterior horn of the lateral ventricle. And looking backwards, you can then see the head of the caudate nucleus laterally and the septum pellucidum medially, separating the two lateral ventricles from one another. Moving into the body of the lateral ventricle, you can still see the caudate nucleus and the septum pellucidum, but now on the floor you can see the thalamostriate vein together with the choroid plexus. And as we move posteriorly, you will be able to see how this ventricle curves down into the temporal lobe and how this posterior horn extends into the occipital lobe. We are actually in the antrum now before entering the posterior horn, and if we turn medially, you will be able to see the calca avus, which is formed by the calcarine sulcus, as well as fibers of the splenium of the corpus callosum. Now, once you turn anterior again, there you can see very nicely the perspective of this antrum or trigone and how the choroid plexus loops into the inferior horn, first starting on the floor of the body, then the anterior horn of the trigone, following into the roof of the inferior horn. You can also see the fornix curling into there, and eventually we will enter the inferior horn and get to the hippocampus. There you can see we're entering the inferior horn, ending in the hippocampus, and then also where the amygdaloid bodies would be. Now, these videos would be perfectly sort of used during this dissection, where we're actually cutting the brain and losing the perspective of this three-dimensional anatomy. Now, this was the abbreviated version of the full video, which also had labels that Edwin made together with the help from the following individuals. Now, in a day where we are competing with the internet, being able to employ one's research in teaching has allowed us to engage with our healthcare students as they are presented not only with the facts, but also clinical scenarios and results directly from current and published anatomical research projects. The studies presented here are but a few of the many that have been conducted and even published during this time when COVID-19 restrictions have limited access to the dissection halls and even decreased donations to the body program. Both before and during these restrictions, the use of imaging modalities as a source of anatomical data collection is clear, either as the sole source of data collection or as an equal addition to cadaveric data. Now, despite the long history of clinical procedures honed and studied on cadaveric material, the inclusion of images to support what is found within the dissection lab can really elevate the quality, visibility, and impact of your research, as well as your teaching of anatomy. For example, the most prominent impact was the ability to include the knowledge and skills acquired during our ultrasound research and apply it to undergraduate anatomy teaching. This very practical application of anatomy knowledge is meant to stimulate the students' interest prior to dissecting the area. I would like you to show this brief video of how, prior to the dissection of the upper extremity, we spend about 10 minutes to give an introduction to the use of ultrasound, as well as the anatomy of the neurovascular and musculoskeletal structures of this area.
Videos doesn't work. All right, so the first thing you need to know about an ultrasound is that you're basically sending sound waves into tissue, and certain tissue will then reflect that sound back, which is taken up or picked up by this probe here. All right, so this is a linear probe, which allows for a little bit better resolution, but it also, the waves are going in straight. So the information is coming back straight. You do get curvilinear or curved probes as well, if you want to see deeper structures, like the abdominal probe, which I'll try and show you guys some abdominal structures when we do the abdomen. Now I'm going to show you musculoskeletal and arterial structures. All right, so just know that if you are placing the probe sort of as a cross section on the arm, all the structures running longitudinally through the arm will appear as circles on the screen. You're basically making a cross section through the arm, and then that's what you're seeing. If you turn it longitudinally, you will see an artery as a long structure running through the screen. All right? I'll show you all these things. The next thing that you need to know is that there's a certain landmark that you can see there. That always refers to a landmark on the screen. Natalie, if you can go there, you can see there's the landmark. All right. So on the screen, you can always see what you're looking at. I'm going to try and see my brachial plexus very quickly. There you can see my brachial plexus quite nicely. Paul said, can you show it in the...
There's an artery. Then around it.
All right. So don't pay attention to that small biceps that you see there. Just look at the brachial artery that you can see. Natalie, can you place, what is that, color? Doppler.
Where's Doppler?
Doppler there. Okay, and move it into there. Okay. There's your curve, select. And click color. There, just below Doppler. Right, can you see the blood flowing through my artery there? So I've confirmed that that is the brachial artery. All right, you can't see it, sir. You can turn around if you quickly want to look. Oh, you can see it on the screen there. All right, so that is just to show you. If I try and turn it so that we can see the brachial artery as a long axis. Oh, there's just a little bit.
You can see it there.
Yeah, there you can see it. There's my brachial artery. This is a long axis. Natalie, can you show the probe quickly? Look at where the probe is. It's now a long axis around the arm. And then you can see the artery beating in a long axis. Now, please remember, the blue just says that the sound is traveling away from the probe. Red means that it is towards the probe. I can dictate how I want the color to really be, but it does help in a clinical setting. All right. But that's not what we're showing you today. We'll show brachial plexus another time. I'm going to show you a little bit of the anatomy. What are...
All right. So you can see it's a fairly informal video that we made in the dissection hall, but we tried to do that for every region that is possible, where we could show the ultrasound anatomy and then have the students dissect that area. They really enjoyed that aspect of the dissection. That was in 2019. Now, unfortunately, obviously with the limited dissection time that we had, we couldn't really do that anymore. But that is just one point of the teaching that we've been able to include. Now, regarding the prospective research that is planned for the future, well, firstly, Dr. Govender has already started recruiting Dr. Moore as a potential PhD student that we will be supervising using similar research techniques that she used in her PhD, but on the pericapsular nerve group in order to provide anesthesia for hip surgeries in adults. Now, this is extremely novel, and there are very few research publications on this block currently available worldwide. So we're quite excited for this one. Another long-term study that that is being designed in joint collaboration with the universities of Auckland and Toronto is the digitization of muscle fibers of the calf muscles. What we know is that the calf muscles make up a very important portion of the leg significantly involved in cerebral palsy expression, which makes early detection of non-weight-bearing infants very difficult. The aim of this study will be to investigate the architecture of the calf muscles and tendons prior to weight-bearing using digitizing hardware and software to create three-dimensional virtual models of the normal anatomy. With the creation of a normal anatomy model, it will hopefully allow for the early detection of cerebral palsy in the very young, which in turn could serve to promote more targeted and truly helpful interventions to improve the quality of life of the children that are diagnosed with cerebral palsy. Now, at this point, it's at this point that I would like to take some liberties of my unique platform to speak to the students, the emerging anatomists, and my colleagues. And to do this, I have to go back full circle to the point that I made at the beginning of the presentation about starting my academic journey as a technical assistant in the department. The one thing that I would like to draw your attention to is that none of these studies were ever done alone. Also, none of the awards, accolades, and achievements that I was fortunate enough to receive was ever possible without the hard work, guidance, and support from others within the field. Over the past 18 years as an anatomist, I've come to the conclusion that firstly, the ability to conduct really meaningful and translational anatomical studies, you need to have the active input and participation of an enthusiastic clinician. I've been fortunate to have met with many clinicians that fit this profile early in my career, and I'm even more fortunate to be still working or in contact with many of them. My second realization is that the research that you conduct are vehicles that give students the best possible opportunity to engage and remember the work that you are teaching them. Your enthusiasm sparks curiosity, and their curiosity heightens their thirst for knowledge. Keeping that in mind, the third point that I would like to make is that you have to conduct the research that you are passionate and enthusiastic about. It is difficult to fake enthusiasm to a class of students or to your postgrad students. It will also help you push through the writer's block, the rejection letters, and the endless hours of administration that accompanies any research project. My fourth and final point is perhaps a sobering one, but important nevertheless. The role of an anatomist within a good research team is very much like being a technical assistant. The work we do is fundamentally important to the daily work of clinicians who treat the patients. Our work remains collaborative, which often means that regardless of how translational the research is, we do not see the results of our hard work. It also means that individual honors and recognition is perhaps not what we are destined for. But like any good technical assistant, the recognition comes from our colleagues and peers, our mentors, and our students. It comes from the frontline clinicians who perhaps might never know us, but internalizes the results of our research and improves their anatomical knowledge to the benefit of their patients. So with that, I would like to thank everyone who has watched this address, the staff of the Future Africa, as well as the kind staff of Louis Klute Productions. I wish you all a warm and safe sort of evening and wish you a blessed year ahead. Thank you very much.
Ladies and gentlemen, please allow me to thank Professor Albert van Schoor for his illuminating inaugural address that focused on the presentation of conventional and modern imaging modalities for anatomical research. The COVID pandemic affected us all and thus made many of us rethink various aspects of teaching and learning. Prof. van Schoor's address reflected on the critical role that clinical anatomical research plays in the clinical arena, how this research is driven by collaborative anatomy teaching, and how the research guides the teaching. I hope many will be encouraged to use collaborative methods in teaching the discipline of anatomy while being guided by research. Finally, allow me to thank Professor Norman Duncan for leading us in this inaugural address. Members of the University of Pretoria Executive, for your support through these unpredictable times. Faculty Executive Committee at the Faculty of Health Sciences, the team at Future Africa and Louis Klute Productions, thank you for making this inaugural address possible. Distinguished guests, staff, students, and audience, thank you for joining us this evening. Stay safe and good night.
Gaudiamus igitur juvenestum sumus. Gaudiamus igitur juvenestum sumus. Post jucundam juventutem, post molestam senectutem, nos habet